Hi everyone, I'm Georgia and this is Kat. We are two-thirds of the 2025 MOGIG academic team. And we're hopping on today to give you a little PSP on some gynae-onc topics and incontinence, also made with the help of our third member, Joan, who's currently away. So to kick us off, we just wanted to put a little disclaimer at the front. We've done our best to create accurate content based on guidelines, which we've linked in the slide notes, but we may have some unintentional errors or omissions. So we've tried to use the RANZCOG or Monash guidelines where possible, but feel free to let us know if we've made any mistakes. So today we're going to be talking about gynae malignancies, including ovarian, endometrial, cervical, vulvar, and vaginal, as well as stress and urge incontinence. So I'll hand over to Kat to take us away.
Okay, so let's start off by talking about ovarian carcinoma, which is an R1. So it's pretty important to know well, and it's also unfortunately quite common cancer. So in terms of the statistics, it's the second most common uh, gynecological cancer, and it's the seventh most common cancer. So like across the world, in women, unfortunately. And if you have a look, so here at the graph, you can see that like in terms of mortality, it's the fifth highest in 2023 here. So that's quite sad. In terms of the peak incidence, so it's 50 to 59 years, and the 5-year survival rate is unfortunately 49%. And the reason why is it like tends to just be diagnosed, at like quite like an advanced stage. And we can probably like attribute that to the very like non-specific, the symptoms or the way that it presents. So in terms of the risk factors, it's thought to be like related to having like a high number um, of like ovulatory cycles. And the reason for that is like you have more cycles, and so you have like more replication, and there's a higher chance that there's an error there, and then that goes, and causes cancers. So that can include like things like an earlier age of menarche. So if you've never had a baby, um, or uh, or if you had like a late onset of menopause. And then you have family history. So unfortunately, if you have a patient who has a first degree relative who had this cancer, then it's higher risk. And also the BRCA1 and BRCA2 mutations, as well as Lynch syndrome, and of course, smoking is a big risk factor. So unfortunately, the way that it presents is quite like non-specific, and it can kind of just fly. It can fly under the radar until it's too late. And so the way that like I used to remember it is like BEAT, right? So the B is for your bloating and your bowel changes, and then your E is for early satiety or indigestion. A is for like abdominal pain, and T is your like troubles with like urination or defecation. Right? And then in terms of the like acute way that it can present, so it can cause like ovarian torsion, and then it's like if it's spread like to the lungs, it can cause like pleural effusion, so your shortness of breath. And so like if it's spread to the bowel, it can cause a bowel obstruction, or like with all cancers, it can increase your chance of like VTE. So like anytime that you have a patient who is like postmenopausal and has like non-specific, symptoms like these, I would encourage you to think about ovarian cancer. Next slide. Yeah. So there are many, many different types of your benign and your malignant cancers, and I won't go through all of them today, but just be aware that there are lots of them. And so the three main types that we talk about, like with the ovarian cancers, is the epithelial cancers, right? So the cancers that are from the lining, like of the ovary. And important to know that this also like includes the cancers that have come from the distal like fallopian tube as well. And then there are the germ cell tumors, right? So the tumors that come like from the cells that would like develop into your eggs, and then the stromal tumors as well. And so here you can see like all the different subtypes, and so it's just important to know that the most common is the epithelial type, and then within that there's the most common type, which is the serous subtype there. And this is a common kind of question that comes up like in your exams. So if you have like tumors like in both ovaries, it's important to consider that it can be like metastases. So the common one is the Krukenberg tumor, which is actually like it's like it's a metastases that has come from your stomach cancer. So your adenocarcinoma. So, okay, let's have a look now at the examination findings. So you want to start with your inspection and your vitals, and you want to feel the tummy to see whether there are any masses you can feel, and you want to check for ascites, which can be the result of like metastases. And then you want to do like speculum to check for any like abnormal bleeding or any lesions you can see, and then a bimanual to see whether you can feel so any masses there. And then, so in terms of your like investigations, you want your baseline blood, so your FBE, your LFT, and your UECs. And then the important one to remember in your postmenopausal woman is your CA125. This is the common sort of tumor marker that we think about for ovarian cancer. And then there's also these other kind of tumor markers, so your AFP and your LDH, and you can think about those in your patients that are under 40, because there's a type of cancer called a germ cell tumor that would cause those to be high. Obviously, if your patient like is still like premenopausal, then you want to exclude pregnancy, so beta HCG, and also there's a CEA that you can order, which is another type of tumor marker. And then in terms of your imaging, so your gold standard is your transvaginal ultrasound. This is probably the most important one that you're going to do. And then if you're thinking like about staging, then you can do like CT scans or a PET scan, things like that. And then in terms of like getting an actual tissue sample, it's important to know that with like ovaries, we don't do any like biopsy, like a needle biopsy or anything like that. And that's because there's a risk of like seeding the cancer. Right? So the same thing as like testicular cancer, there's the risk of spreading the cancer. And so if there's any suspicion that this cyst like is cancer or anything like that, we just like take it out. Yeah. And also, so currently there is no like screening program. And the reason is that the CA 125 is a bit like unreliable because it can cause some high false positive rates as well. All right, and then so after you have done those tests, so we use them in something which is called the RMI score. All right, so it's called the risk of malignancy index, and it's used to assess the chance that this lesion that we found is actually cancer. So it combines the ultrasound findings, it combines the patient's menopausal status, and also the levels of their CA CA125, and it produces a score essentially. So if the score is between 25 to 200, it's a bit suspicious. So we refer to a gynae-oncologist for a second opinion, essentially. And then if it's higher than 200, that is highly suspicious for a cancer. And so we refer to the gynae-oncologist quite urgently for staging and things like that. And here you can see that there are some features on the ultrasound that point towards a benign lesion or a malignant lesion, and just know that they exist. And then obviously for management, so we're going to refer to the experts, right? So the gynae-oncologists, and so as is the case with every cancer, it's going to depend on the type of the cancer, on the staging, but surgery is going to play a part here. So you can do a staging laparotomy, and you do a total abdominal hysterectomy and a bilateral salpingo-oophorectomy. And then I guess depending on the staging, you can also take out the omentum as well. And also there is a role for your chemo and also radiotherapy. And here you can see the staging, right? So it's stage 1, the cancer is in the ovary or in fallopian tube. So in stage 2, it's spread to other organs in the pelvis. That includes the uterus, the bladder, or the bowel. If it's stage 3, it has spread to the peritoneum or lymph nodes. And if it's stage 4, it's spread to the distant organs, to the liver or the lungs. All right, so let's talk about endometrial carcinoma. Okay, so surprisingly, it's actually the most common gynecological cancer in Australia, and the number of cases have almost doubled in the last 20 years, unfortunately. And we'll talk about why that is. It's the 5th most common cancer that is diagnosed in women in Australia, and has a peak incidence between 65 and 75 years, but we do see it in some younger women as well. And so in terms of the 5-year survival rate, it is higher, so 83%. And so that's probably because it's detected earlier compared to ovarian cancer, and so it's treated earlier. So the risk factors, obviously, if you have any endometrial hyperplasia, there's the risk that will it will turn into carcinoma. And so estrogen, so it causes exproliferation, essentially, causes growth of the endometrium. So if you have greater exposure to estrogen, so you had again so earlier age of menarche, or you had a late menopause, or you never had a baby, or if you were to take estrogen only HRT and you had a uterus, so all of those things are going to increase your chance. And then so obesity has quite a big impact as well. And the reason is that fat tissue is a source of your estrogen production. And so even after menopause, if you have more fat tissue, that increases the risk. And then PCOS, again, because you have cycles where you're not shedding the endometrial lining. And there is also an association with Lynch syndrome, and with older age, and with a drug called tamoxifen, which is used to treat breast cancer, and it's an antagonist at the breast tissue, in terms of estrogen, However, it also has some agonist activity at the endometrium. So in theory, it can increase your risk. So in terms of how it presents, the number one sort of, like red flag that you hear is postmenopausal bleeding, right? So always think about like cancer if you have a patient has postmenopausal bleeding, right? But any sort of like abnormal vaginal bleeding, so intermenstrual bleeding, if you have like really, really heavy bleeding or constant bleeding, that could be a sign of endometrial cancer. And you have these other symptoms, which again, like are not very specific, but some abnormal discharge. If you have any trouble like with the bowels or the bladder, and of course, if you have any unexplained weight loss. So here we can see the progression. So it starts as endometrial hyperplasia, which means that there are more cells, but they're not necessarily changing in their appearance. And then you have endometrial hyperplasia, and so with atypia, which means that the cells or the nuclei are starting to look a bit suspicious or a bit different. And then eventually it will turn into a cancer. So again, on inspection, you start with your, on examination, you start with your inspection and vitals. You want to feel for any masses and do a speculum or a bimanual as well. And then for your blood, so your baseline, your FBE, your LFT, and UEC, and you want to exclude any pregnancy. And then again, the gold standard is going to be a transvaginal ultrasound to assess the thickness of the endometrium. And so the cutoff, like for us to be concerned, is going to be different if the patient is like premenopausal or is postmenopausal. So if they're premenopausal, if the thickness is greater than 15 millimeters, then we will consider doing a biopsy. And then if they're postmenopausal, like obviously it's going to be like thinner. So if it's greater than 4 millimeters, then we would do a biopsy. And then in terms of like how we do that biopsy, there are two ways. And so there's a PIPL, which you can see here in the picture, right? That can be done in like an outpatient setting. So there's no GA that's required, or you can do it through a hysteroscopy as well. And here you can see the staging. All right, so stage 1, and the cancer is still in the uterus. In stage 2, it can spread to the cervix. In stage 3, like it'll go outside the uterus, but it's still inside the pelvis, so that can be to the ovary or to lymph nodes. And then stage 4, like it's gone to distant sites. So in terms of the management, we're going to refer to the gynae-oncologists. And so the management is going to depend on the type of hyperplasia or cancer that we're dealing with. So if it's hyperplasia, but there's no signs of atypia, then we're going to prescribe some sort of like progestin therapy, because we know that progesterone causes the lining to thin out, and so that's the mini pill or the Mirena. And then if we have hyperplasia and there are signs of atypia, and it's recommended to do surgery, so a hysterectomy or an ablation of some sort, in order to prevent it like turning into cancer. And then if it is endometrial carcinoma, then we do a total abdominal hysterectomy and BSO as well. However, it is also important to discuss with the patient like about their their fertility goals because, as we said, uh, um, this cancer can happen like in your patients who are in their 30s or their 40s, and they're still um, they're still they might like want to have more children. And so again, it's a it's a it, it's a case by case basis. And so they might want to have like a pregnancy and then have surgery afterwards.
So next on to cervical carcinoma, which is also an R1 condition. It accounts for about 1.4% of new female cancer diagnoses in Australia, 75.5% 5-year survival, and an Australian woman has a 1 in 175 risk of diagnosis with cervical cancer by the age of 85. But most people will develop it between age 35 to 40-ish, and most certainly are diagnosed before age 60. So, plenty of risk factors to be aware of, but the biggest one is its association with the human papillomavirus infection. So, genital HPV is spread by genital skin to skin contact during sexual activity. And then it takes about 10 to 15 years for the HPV to develop into cervical cancer after that contact. Other risk factors. So, the risk of cervical cancer may be higher with sexual activity at an earlier age, with multiple partners, or with a sexual partner who's considered high risk. People with a weaker immune system because they are unable to clear past HPV infections. And apparently, concurrent chlamydial infections are associated with increased risk. Other risk factors include smoking, oral contraceptive pill use for more than 5 years, and in utero exposure to DES, which was a synthetic estrogen given to prevent miscarriages until 1971, but no longer given. Important to know. So, cervical cancer is often picked up with our cervical screening, which we'll talk about later. But if it does present with symptoms, you'll get symptoms of abnormal bleeding, which includes intermenstrual bleeding, menorrhagia, postcoital bleeding, or postmenopausal bleeding. You can also have dyspareunia or pelvic pain with it. And if it presents at the advanced stage, then obstruction of local structures may present with edema, loin pain, rectal bleeding, radiculopathy, hematuria, or urinary retention. Most are squamous cell carcinomas, but you can get adenocarcinomas or a mixed path. And it's a progression of cervical intraepithelial neoplasia to dysplasia, to carcinoma in situ to invasive carcinoma. So on examination, you might see signs of spread on the abdominal exam, so hepatomegaly with METs or rectal bleeding if it's locally advanced. On pelvic exam, so a speculum you might see a bleeding ulcerated lesion. There might be some abnormal discharge, and you might notice a pelvic mass on bimanual, for example. You might consider an STI screen, given chlamydia is one of the risk factors, and you'll investigate with a colposcopy and a biopsy if you're suspicious. Once a diagnosis is confirmed, you'll do some further investigations to look for METs, so a CT abdo-pelvis, and then you might consider MRI or PET scans. So in terms of the staging of cervical cancer, basically, like all others, you start with relatively confined to local structures, followed by spread parametrially, for example. Stage 3, you get involvement of the lower third of the vagina or the pelvic wall. And stage 4, you have growth to adjacent or distant organs. So you're going to refer to Gynae-Oncology, and you might offer, for example, a cone biopsy if it's quite small, and usually stage 1. A trachelectomy, which is shown in the image below, is a fertility preserving options option, or otherwise, people might opt surgically for a radical hysterectomy. If the cancer is quite advanced, though, we might choose radiotherapy and chemotherapy, and all of these gynae malignancies will be followed up with regular scheduled visits. So prevention is a huge and very high yield topic for cervical cancer. So Australia has a HPV vaccination program. It's a single dose. The vaccine is called Gardasil 9. It's technically given between age 29 to 25, but most people get it in year 7. Um, but people who are immune compromised will get additional doses. So the second half of our prevention program is the cervical screening test, formerly known as the Pap smear. This is done in people aged 25 to 74 who have a cervix, and it's done every 5 years if the results are normal. So we take a sample close to the transitional zone of the cervix, which is the squamocolumnar junction. And this test, first of all, checks for the presence of the virus and the strain, and then can also do a liquid-based cytology, referred to as LBC, which will give you the cervical changes on a cellular level. So low-grade changes are equivalent to SYN1, the high-grade changes are equivalent to SYN2 and 3, which we talked about before in the path slide. So this is a really high yield flow chart. It's basically how our cervical screening test works. So people can either do a self-collect or a clinician-collected sample. If they do a self-collect, it will just screen for HPV, so just the first row at the top. And if HPV is not detected, then they can go back to routine 5-yearly screening and forget about it for the meantime. If it was a self-collected sample, the person will have to go back to their doctor to get a clinician-collected sample to do the liquid-based cytology. If they had a clinician-collected sample to begin with, this will just happen automatically, this next stage. So if we find HPV, we'll either figure out if it's the strain that we are most worried about, which is 16 or 18, or we'll find out that it's non-16-18. So for the 16-18 strain of HPV, which is considered the most oncogenic, if there's any cervical cell changes, then the person will get a colposcopy. If they find HPV, but it's not 16-18, then we will either have to repeat the test. It will be negative, in which case they will get a repeat HPV test in 12 months. If they get low-grade changes, they'll get a repeat test in 12 months. And if they have high-grade changes with HPV non-16-18, then they'll get a colposcopy. And I'll leave you guys to go through the rest of the flowchart in your own time, but that's the general gist of it. So once we have picked up a result on a cervical screening test, we'll use colposcopy to investigate further. So we'll paint the cervix with 5% acetic acid and iodine, which will turn cancerous cells white. And then during this time, we can get a biopsy. To treat it, we can excise with a cone biopsy or a large loop excision of the transformation zone. It can be ablated with a carbon dioxide laser, or we can opt for cryotherapy. And usually any results are followed up by extra co-tests. So moving on to vulvar cancer now, which is an R2. So it's a rarer one, 0.57% of new female cancers with a 74% 5-year survival. The incidence increases with age, and this refers to cancers that occur at the labia majora, labia minora, but also the perineum, clitoris, and Bartholin's glands. Risk factors include the HPV infection, but you can also get precancerous skin lesions, like VIN, and lichen sclerosis also predisposes you to developing vulvar carcinoma, and other gynae cancers. Having a history of one of them is a risk factor for developing vulval carcinoma. You can present with a vulval lump or itch, and they can be ulcerated and they can bleed as well. Most of them are squamous cell carcinomas, but you can also get melanoma, adenocarcinomas, sarcomas, and BCCs. And the precancerous lesion here is referred to as vulvar intraepithelial neoplasia or VIN. You can do a colposcopy as well for VIN, plus a biopsy. You need to do a chest x-ray to look for lung mets in this case, and other staging scans would be a CT, MRI, or PET. Like all of these gynae cancers, we're going to be referring to Gynae-Onc. The surgical option is a radical local excision plus or minus a lymph node dissection, and potentially a vulvectomy for more advanced disease. We're considering radiation or chemo. And the management of VIN, you can either use immune modulating creams like imiquimod, there's also laser therapy, or it can just be excised. Onto vaginal cancer, which is an R3 now. So these are quite rare. And our risk factors are HPV infection, DES exposure, smoking, untreated precancerous lesions, which in this case are referred to as VAIN. If you've got a past history of cervical cancer, any prior radiotherapy to the pelvis, or age over 70, other risk factors. Most, again, are squamous cell carcinomas. It's more common to have a secondary or metastatic cancer than a primary vaginal cancer, though. And I've already talked about the precancerous lesion. So people will present with blood-stained vaginal discharge, postcoital bleeding, potentially a pelvic pain or a vaginal lump. They can present with hematuria, frequency or nocturia, or rectal pain. Again, investigation is with colp plus biopsy, plus or minus the staging scans. The management, as for all cancers, is going to be refer on and get rid of it, however, is appropriate. And there is staging according to the FIGO system, but this is less relevant for our R3. So onto bladder anatomy and pathology now. So we're going to be talking about incontinence. So essentially in stress incontinence, we are looking at our external urethral sphincter and the pelvic floor muscles. And in our urge incontinence, our affected anatomy is going to mostly be the detrusor muscle of the bladder itself. In terms of the anatomy of the pelvic floor, the levator ani is composed of the three main muscles, the puborectalis, the pubococcygeus, and the iliococcygeus. And so with stress incontinence, we see increased intra-abdominal pressure, and with bladder outlet incompetence. So possible causes include urethral hypermobility or an intrinsic sphincter deficiency. In urge incontinence, we get autonomous contraction of the detrusor muscle. And in overflow incontinence, we get impaired detrusor contractility or bladder outlet obstruction, which obviously BPH not quite relevant to gynae, but just another cause of overflow incontinence in general. So to speak more specifically about stress incontinence, you get involuntary urine leakage during activities that increase intra-abdominal pressure. So things like coughing and sneezing and jumping. It's more common in females than males, and the epidemiology increases with age. Risk factors would be multiparity, pregnancy, or more specifically, normal vaginal birth, or just vaginal delivery in general, I suppose. High impact activities, menopause, obesity, smoking, chronic cough, chronic constipation, and pelvic surgery or trauma. The two main mechanisms, you get urethral hypermobility, with weakening of pelvic floor muscles and connective tissues. So you get less support of the urethra and bladder neck. and the intrinsic urethral sphincter deficiency, which occurs with age, post-surgery, post-radiation, or with neurological damage. So you'll get involuntary urine leakage, like I said before, with coughing, sneezing, laughing, lifting, or exercising. It's typically a small volume leak. You don't tend to get urgency or nocturia, which differentiates it from urge. It's common in postpartum, perimenopausal, postmenopausal women and people with pelvic floor weakness. Um, so to diagnose it, we ask our patients to take a detailed bladder diary of the frequency, volume, and triggers. And this can help differentiate between causes of incontinence. We also like to find out impact on quality of life to help guide our management. And it's important to get the relevant obstetric, surgical, and gynae history and to rule out red flags like hematuria, pain, or recurrent infections. On a pelvic examination, we might find a vaginal wall prolapse. We might be able to assess pelvic floor muscle tone. Um, and stress testing, which can involve asking the patient to cough or strain with a full bladder while observing for leakage. And the Valsalva might help exacerbate that. A urinalysis would rule out a UTI, and a post-void residual volume should be normal with stress incontinence. If you're unsure on the type of incontinence you're dealing with, then a urodynamic study may help differentiate. So, conservative management of first line. So we want pelvic floor muscle training. There are pelvic floor physios who can help out with this, commonly referred to online as Kegel exercises, and other lifestyle modifications like weight loss, reducing caffeine, reducing how much people drink, um, and treating chronic cough and constipation as well. Pharmacological options are quite rare for stress incontinence, but they include SNRIs like duloxetine, which increase muscle tone in the urethra, which would prevent that leakage. Alpha adrenergic agonists would cause the muscles around the bladder neck and urethra to contract. And topical vaginal estrogen may help if it's associated with atrophic vaginitis. Surgical management options later down the line could include a mid-urethral sling, bulking agents, which are usually injections around the urethra, urethropexy, which is quite an invasive option, requiring laparotomy or laparoscopy, or bladder neck suspension using tension-free vaginal tape or transobturator tape. And onto urge incontinence. So we get autonomous or uninhibited contraction of the detrusor muscle, which causes a strong, sudden urge to void. Similarly, we've got more females than males affected, and their epidemiology increases with age. Risk factors are recurrent UTI, bladder symptoms in childhood, including bedwetting, obesity, chronic constipation post-menopause, caffeine, alcohol, and excess fluid intake, or diuretic use or alpha blocker use. We can see urge incontinence in neurogenic disorders, or with bladder irritation, but quite a few will be idiopathic in nature. So for the diagnosis of urge incontinence, we follow the same kind of algorithm as stress incontinence, starting out with a diary of bladder habits, I suppose, going all the way down to more invasive testing like urodynamic studies. Management, so first line, we like to try bladder training. So with timed voiding, urge suppression, for quite a prolonged period of time, so 6 to 12 weeks, and other lifestyle modifications that can help urge incontinence include reducing caffeine and alcohol intake, appropriate timing of your fluids, and weight loss as well. Pharmacological management is a bit more common in urge incontinence, so options include anticholinergics like oxybutynin, which reduce involuntary detrusor muscle contractions, beta-3 agonists like mirabegron, have fewer anticholinergic side effects, but are contraindicated in uncontrolled hypertension. And again, topical vaginal estrogen if there's an element of postmenopausal atrophic vaginitis contributing. For second line and refractory urge incontinence, we can consider botulinum toxin A injections into the detrusor muscle, neuromodulation with sacral nerve stimulation, and surgical options, which are rarely indicated for urge. So that is the end of our first PSP for the year. Thank you so much for listening, everyone. Here is a QR code. If you found any issues, please give us some feedback if you find anything that's incorrect, and look forward to seeing you at the next one. Thanks so much.